Oh, great. She's here. Perfect.
Fantastic.
Right on time.
Yeah. Awesome. So we're live. So let's get started. Hi everyone for joining us. Really excited about this conversation actually. But before we get started, I'd like to introduce myself. My name is Jason Amate. I am a PhD student at the University of Nottingham in England, and I'm very, very delighted to welcome you to this event. Catherine, would you like to introduce yourself?
Sure. Hi everyone. Welcome to our fourth day of Black in Cardio Week. My name is Catherine Chandra. I'm a postdoc at the University of Stanford, and I study a genetic risk factor for cardiovascular disease. And I'm
Fantastic.
really, really delighted to have you today on our panel.
Awesome. So I'm going to get everyone to introduce themselves, and I'm going to go along my screen. So the first person is Dr. Thomas.
Hello, everyone. My name is Stephen Thomas. I'm a professor in the Department of Health Policy and Management at the University of Maryland in College Park School of Public Health, and I direct the Maryland Center for Health Equity. My work is focused on translating the science of medicine and public health into culturally tailored community-based intervention. So happy to be here with you today.
Be here as well. Next, we have Ogechi.
Hi, I'm Ogechi. I'm a second year PhD student at University of London in psychology, and I also work in an NHS as a tobacco dependence specialist in a psychiatric setting.
Lovely to meet you. Dr. Morris?
Hi, my name is Alana Morris. I am a heart failure cardiologist at Emory University in Atlanta, Georgia. And my research looks at both race and gender disparities in heart failure, looking at both biologic determinants as well as social determinants of disparities in both heart failure risk as well as heart failure progression and outcomes.
Fantastic. Dr. Hudson?
Hi, everyone. It's happy to be here. And I'm an associate professor at the Brown School at Washington University in St. Louis. And I mostly study racial ethnic health inequities and figuring out ways to reduce those inequities. And most of my outcomes have to do with the intersection between chronic disease and behavioral health.
Fantastic. Lovely to meet you. And Dr. Breth, am I saying that right? Breth?
Hi, good morning, everyone. My name is Dr. Khadija Bretha. I'm a heart failure transplant cardiologist at the University of Arizona, as well as a physician scientist. And my work is focused on reducing racial, ethnic, and gender disparities in heart failure. I'm a K awardee for addressing how to make the allocation process of advanced heart failure therapies more equitable. Thanks for having me.
Thank you. Well, welcome to everyone here, and thank you for taking the time to join us on this special event. So the title of this this webinar is Changing Narratives Around Cardiovascular Health, Destigmatizing Research on Black People. So the common theme in all your work here is that, all your work is focused around research in racial disparities in health. So my first question to all of you is, what were the factors that drove you into this area? And I'll start again with Dr. Thomas, if you'd like to go first. Or Professor Thomas, I should say.
No. You know, the history of racism and discrimination in medicine would be easy to ignore were it not so well documented. And so when I was a young scholar working towards my PhD, is when I learned about the Tuskegee syphilis study, which is now recognized as the most egregious example of research abuse. I was in my doctoral program when I first heard about it, and the book Bad Blood. And I'm not a historian, but I got completely enamored with medical historians, and then realized that throughout history, even back in the time of Africa, during the slave trade, our bodies, our Black bodies, were the raw material for the research that now we all benefit from today. And so we've all heard about the apologies. An apology means I'm sorry. An apology is coming from people who weren't even alive back in 1932. We need to move towards atonement, which means making things better. And while we have these ethical principles of respect for persons, get informed consent, beneficence, do no harm, the principle of justice means those who bear the burden of research should not be denied the benefit. So I submit to this audience that the campaigns to eliminate racial and ethnic health disparities is part of that atonement. I won't call it reparations, we'll call it atonement. And COVID has exposed how we are still being denied, how we still have a blank check, so-called, in the healthcare delivery system, how Jim Crow in the US context hides in our healthcare delivery system. And that's why we're doing so bad when you look at the COVID case rates compared to you there in the United Kingdom. So once I discovered public health, I never turned back. And I never forgot where I came from. And if we have time today, I'm going to take you to where I discovered how to reach our people in the Black barbershops and beauty salons.
Getchi?
Hello, can you hear me?
Yes.
So I think parts of my research is on medical help seeking behaviors in the Black community here in the UK, especially those who are seeking help for cancer symptoms and the impact COVID has had, where we're seeing a lot of backlog in cancer patients having their appointments cancelled, especially those who have gone from different stages of their cancer. And within our community, there's this hesitance, like Dr. Morris has said, that Dr. Thomas, sorry, has mentioned that there's that hesitance because of the Tuskegee experiment and all these other experiments where Black people's bodies have been used as experiments to tamper with. There's that, hesitant to say, I don't want to be used for research. Just like with this situation, we've seen, people are scared to even get the flu jab, where the flu jab has historically saved lives. The vaccines are getting better. There is no evidence to suggest that it causes autism, but we still have these biases and conspiracy theories that suggest that Black people don't want to seek help because of discrimination, or their doctors or medical professionals will not take their pain seriously. They will not take their symptoms seriously. And by the time it's too late, the media, different people will come out and do advocacy on improving awareness around, we need to do more for this community. They are disadvantaged, which we have to change that. And I think this is what motivated me to do my PhD in psychology and understanding the behaviors and breaking down barriers, because it's not just, the racial bias, it's also the language, the cultural traditions, especially in our community, where some of us will say, oh, I don't need to go to the doctor. I just need to drink this, what they use back home, and I'll be good. But by the time they go to the doctor, the GP say, you've left this too late. Now we have to go through something, more instrumental and try and, delay anything from going further. So that's probably one of my motivation to try and improve understanding and research. And I think also seeing Black researchers will encourage more Black people to take part in research and not have that bias idea that, oh, they're going to experiment on us, or we'll be like the Henrietta Lacks and all these other, unfortunate people that have gone through this and never got an apology. Their families never got an apology about, being used against it without consent. So I think this is the right time in 2020, where I'm so happy I'm seeing more Black people going into research and debunking myths, providing facts and improving the understanding and information around clinical research as well.
Absolutely. And you mentioned about debunking myths. That's exactly what we want to do in this session, is to change the narrative on what's out there. Yeah. Dr. Morris?
Yeah, so I mentioned I'm a heart failure cardiologist, and I practice in the southeastern part of the U.S., where rates of heart failure hospitalization and mortality are really the highest in the country. And in a day of rounding on service at our hospital on the advanced heart failure service, so we take care of probably the sickest heart failure patients in the hospital, but we also take care of the minority of heart failure patients in the hospital because we're the advanced heart failure service. If I round on 30 or 40 patients in a day, I would say that 75% of those patients are African American. And so there's just a disproportionate number of patients on our service, and really on all of the services in the hospital with cardiovascular disease and heart failure, that are Black. And the question is why? the question is, why is it in our community that there is such a disproportionate impact of heart failure? And there are so many unanswered questions. And when I was reading the literature as a medical student and a resident and a fellow, there seemed to be so many unanswered questions that weren't completely tackled. Certainly there were reports of non-adherence and socioeconomic status, but there, I think, were other unanswered questions related to nitric oxide bioavailability, vascular dysfunction, implicit bias, and other questions. And it seems as though this, sort of complex problem is multifactorial, and that was what spurred me to get into this area and do this research to try to answer some of these questions. It's a huge problem, but at the end of the day, my community was suffering, and I wanted to be part of the army of people, hopefully, that was aiming to tackle this problem and hopefully end some of that suffering.
Fantastic. And Dr. Hudson?
Yeah, sure. I think what brought me into this area of work was really about my own lived experience. I'm a native of Detroit, Michigan. And if you know anything about Detroit, even over there in the UK, you hear a lot of negative things about it. And so I got to witness quite a lot firsthand. And I didn't have the words to articulate what I was seeing when I was growing up. The depth and widespread nature of segregation in the United States is just absolutely astounding. And the resources that are patterned and distributed according to where you live, and that affects everything from morbidities to life expectancy, et cetera. The list goes on: quality of education, transportation, opportunities for employment, and it goes on and on. And what was puzzling to me is that people would see these things, and like Dr. Thomas mentioned, we've documented these differences for a long time, but people's analysis of those problems will always end up with these kind of like very rudimentary, either cultural deficit arguments or genetic arguments that have been long debunked. And so I was like, what is happening here? And I really felt like from a lived experience perspective, I can shed some light onto that. So that's really what brought me into this field, is to try to be an advocate and kind of like a truth teller about circumstances, about people where I'm from and people who've grown up in similar circumstances. And I think what's happened over time is I've been able to, I remember when I finished my doctoral program, people asked me, so what did what's the big takeaway? What did you learn that you didn't know before you went through this arduous process? I said to them, I learned I already knew a lot of this stuff. I just got the tools to articulate exactly what was happening. And so some of those things come through the research literature. I also read a lot outside of, core academic stuff. So one thing Dr. Thomas mentioned, the Tuskegee experiment and the legacy of that. Another recently is the 1619 project that's curated by Nicole Hannah-Jones. I think that gives a really good understanding and analysis of what's happened to Black Americans. Other books like The Color of Law, for instance, by Richard Rothstein, that explains why segregation looks the way it does in the United States and the effects of that. So those are some of the things that brought me into the field, and some of the things that continue to kind of shape the way I think about things.
Fantastic. And Dr. Breathitt?
Thank you. I echo a lot of the sentiments that have been shared by colleagues on the panel today. I knew from an early age that I wanted to be a cardiologist because, unfortunately, this has been an issue that's been plaguing our community for years. And I could see it from an early age that this was killing people that looked like me, racial and ethnic groups of color dying disproportionately from this disease, from things that are preventable. And I knew that I wanted to do something about it. I wanted to see change. And I wanted to be able to take care of patients and to help people see how they can live differently and how they can prevent this disease. But I also saw that there are gaps that are much greater than that, such as social determinants of health, like bias, racism, insurance, health, wealth, education, the list goes on. And I knew from standpoint of research, that I might be able to do something about that, that might be able to educate the masses, change healthcare policy, change the delivery of care in this nation. And so that crystallized into my decision to become a physician scientist, where I spend a small portion of my time seeing patients, but majority of my time is spent doing research to really start to determine how can we create equity in our society, in our country, so that your race, your ethnicity, your sex doesn't dictate what type of care you're going to receive or how long you're going to live. And it's the passion behind wanting to see change and to create equity that keeps me going when it gets difficult, when it gets tough. And it's easy to just return back to my patients and see, what are my patients going through? What are they experiencing, and how can I make it better? And that's what fuels me to continue forward. And it's also encouraging seeing all of these faces here today that are motivated towards a similar purpose, towards a common goal that we can achieve and that we can attain.
That's amazing. You've all shared very lovely stories about your path into this area. Professor Thomas, did you want to share your video before we move on?
Well, I was saying, for the men here, back me up, brothers. No self-respecting black barber would ever say, I'll get you in and out in 15 minutes. Come on now. Doesn't matter how much hair you have, you're going to be in the barbershop for a while, right? No topics off limits. And I always think we should give voice to the people we're trying to serve whenever possible. So some of the barbers use their phones. This is our truth and reconciliation device right here. And we're trying to get all these heart patients, right, to take the flu shot. Right, Dr. Morris? Very important. Take the flu shot. Well, let me tell you what it's like in the shops when it comes to flu. And if the moderator will let me share my screen. Oh, I can't believe it's working. Keep your fingers crossed, people. Here we go. I'm going to take you to the hood. I'm going to take you to the community. And I want you to verify. Someone just say, it's a full screen. You got a full screen? Someone say yes.
Yes.
And yeah. Here we go with the sound.
This is my good customer, Jim. Been cutting Jim for over 10 years. This is my customer, Kyrie. I've been cutting him since he was on phone books. This is a new customer, Ty. This is my customer, Jason. This is my first time cutting his hair. Jason, we just asking the people, how you feel about the flu shot?
They tell you it's like I'm assuming it's like a dead virus or something that they put into you. Honestly, I feel like it's another way for the government or the pharmaceutical companies to just get more money. In my opinion, I always just was anti any shot that I ain't need, even shots that we used to get for school and shit.
Personally, I've always taken a flu shot. Just the idea that you gotta prepare for it. Always thought that's always good.
How you feel about the flu shot?
I never take it.
Why not?
I just never do, and I never got the flu, so.
I just had my flu shot taken last Friday, so yes, I would take that.
Because they haven't gotten a flu shot before, so why should they get it now? Not only that, they're injecting you with the virus. No, thank you.
That they don't know how it's going to affect your body. Everything's not for everybody. You know what I'm saying? So just because it might have cured this person don't mean it won't mess this person's body up, chemical reactions or anything.
As far as the president, what he said, I don't trust him.
I definitely pay attention to what Fauci says. So if he says it's good, then I'm doing it. If it's a no from him, then it's a no from me.
Thanks a lot.
Okay.
All right.
Okay.
All right. I appreciate it, Joe. All right. There it
is. Like they say, there it is. And so, you can make any, your initial observations. I always find it fascinating to hear how people talk. Notice the diversity of opinion. So we're not a monolith. And even though there's a disagreement in there, people still get along. So we've got to figure out how to be in that space to help people and answer their questions. So I'll be quiet and just hear what the challenge and the opportunity we have to get these men flu shots, given the prevalence of heart disease in these communities.
So my question is, which actually links to this video, is why do you think there is a mistrust, or do you think the mistrust that Black people have of scientific research, does it play a part in the racial disparities that we see in health?
I think so. If you heard, they know a little bit about immunology. But he said they put it in you to try to protect you, right? They put something dead in you. So he's got just a little bit, live virus versus dead virus. You know, these are the language we use. But when it gets down to the community level, do you want something dead put in you? So it gets translated in ways that we may not fully appreciate. I'll just do I've never had the flu, so why should I take the flu shot? These are the things that we have to spend more time with, rather than every flu season we come back. Spend time throughout the year addressing their needs, building trust. And notice the barber, he just asked a question. He didn't try to twist arms, he didn't try to convince anybody. And believe it or not, that approach is a positive way of validating what people, of listening. And I don't think we do as good a job of listening. When I showed this to my grad students, the first thing they wanted to do is go in and correct people's assumptions about what they understood. And only afterwards did they realize that Mike, the barber, had the right approach. No judgment. Our people are constantly judged. When they come in for care, as they tell me, the first thing that's said is, Miss Smith, you know, we told you to floss. You know, we asked you to lose weight. Are you eating more fruits and vegetables? It's a constant shame, shame, shame. And that's why they don't want to come back. So I think we need to be out in the community. These devices, the miniaturization, especially in cardiovascular health, I don't need to have a special room, even for a echocardiogram. It's the size of a laptop. Why can't we bring sophisticated diagnostics into the community and therefore remove that one barrier to accessing care? But I'm curious as to what you guys heard, especially my friends in England, because we think everybody over there is getting flu shot because you have the National Health Service, right?
Get you? Do you wanna take that?
So, funny enough, yes, there is a campaign for people to get their flu shots or the flu vaccine, in light with what's going on with the pandemic. But we still have people, especially some patients here, that disagree with taking the flu shot. They'll tell you, you know, it's a conspiracy. They're trying to put chips into you to monitor your movement.
Really?
You still get ill with the flu shots. Sorry?
I'm just saying, really?
Yeah, I think the internet can be, how should I put this? It can be useful, but it can also be used in a way to change people's perception on things. So because there's so much access to information, it's very easy for people to pick up misinformation like we see in social media. You know, the other day I had a colleague of mine, say that this is probably, they're injecting COVID into us. They want to kill Black people off. You know, knowing full well that we don't have a vaccine for this coronavirus at this point in time. The flu vaccine has been around for years, and yet thousands of people still die from flu every year, especially the elderly, especially those who have pre-existing physical health conditions. But I think with some people, again, it comes down to socioeconomic status, their level of education. And we find that some more educated people are willing to take that opportunity to get the flu vaccine to reduce their risk of catching the flu or catching mild symptoms of COVID. I think this time round, you know, post the first wave of the virus, I think we're seeing more of members of the Black community be more careful than they were before, because of the statistics going out saying that we were most likely to die in hospital, or most likely to catch the most virulent strain of the virus. So it's a bit of, it's mix and match really here from what I've seen anyway. But we are trying to encourage more people to, you know, try and use this opportunity to save yourselves, to save your families, because flu on its own, people think it's just a cough and a cold, but it can kill you. Influenza is still a virus, just like any other respiratory virus.
Sure. I just want to remind everyone here that you can ask questions to we've got an amazing panel here with so much knowledge here. So anyone tuning in, feel free to ask any questions. Catherine, did you want to ask any questions?
Oh, thank you, Jace. So I do actually want to go back to that question about how much stigmatization in the Black community, especially for cardiovascular health. And I just wanted to give the opportunity to Dr. Brett and Dr. Morris to give us their thought about that.
Well, I think that, I think that the historical context is really important. Just sort of going back to the conversation that we were having about flu shots, and then the extension of that related to if we do come upon a COVID vaccine for COVID-19. Again, for many years, members of our community perhaps avoided interaction with the healthcare system for a variety of reasons. Number one, because they weren't always treated well or fairly when they interacted with healthcare providers. I think there's still clearly evidence that even in modern times, when members of our community interact with healthcare providers, that their visits are shorter, that there's more verbal dominance when we see providers of different races. So there's modern day evidence to suggest that visits where there's sort of provider-patient race ethnic discordance, that race ethnic minorities are sort of on the losing end when it comes to the quality of the interaction. And I think that many of our colleagues feel that they're providing quality care and don't necessarily feel that they are biased in their approach, and yet the evidence suggests the exact opposite. And this is clearly evidence of Dr. Breathitt's work. And I think Dr. Thomas hit the nail on the head when he said that we should be listening. We shouldn't be judging patients, because again, sometimes their refusal of flu vaccine, perhaps the COVID vaccine when it's available, again, is related to this historical context. For years, many of our parents, grandparents, great-grandparents, et cetera, did not go see a doctor because of Tuskegee, because of now, we've all seen the Henrietta Lacks story, because of, knowledge of the Marion Sims statue that was taken down in New York. I mean, these stories are out there and perhaps are more accessible now than they were in the past. And we have to acknowledge that historical context across the healthcare system before we use terms like non-adherence, non-compliant, and, again, sort of within the context of the way that our healthcare system operates, particularly here in the US, when you only have 6, 7, 8, 9 minutes to see a patient during a busy ambulatory practice, going into all of these things may not be, and you may not be able to do that. You may not be able to address all of these issues, but unfortunately our race ethnic minority patients carry those burdens when they walk into our offices. And that's the reality of practicing medicine in a diverse society.
I think that we're at an optimal time where the disparities are being very clearly illuminated by COVID-19. I think that people that maybe didn't realize it was really happening, or thought that maybe some groups were maybe a little more sensitive, or maybe maybe it's not really happening, that they can actually see that this is real, this is affecting all of us. And if we don't start to treat the least of these that are getting the least appropriate treatment, that we're not going to get equitable treatment for all. Now, I will say that for those that might remember, and this is still, I was earlier in my training then, but about 20 years ago, the Institute of Medicine came out with a landmark paper called Unequal Treatment. And it raised alarm throughout the medical community. This paper illustrated how systematically racial ethnic groups of color are receiving inferior care. And they detailed it very plainly that it's related to social determinants of health, including bias and racism. And they listed a number of different ways that could be used to improve care, improve quality of care to groups irrespective of your race and ethnicity. That include things like bias reduction training, included really seeking ways to treat the social determinant of health, because we know that that is now a very large predictor for developing this cardiovascular disease. And again, with all of that surprise that developed at that time, 20 years later, we're still at the same point, if not worse.
Yeah.
And so this raises the notion that when are we going to really start to take the steps to implement quality care for all people groups? When are we going to start treating social determinants of health? When are we going to start recognizing that even if you feel and you didn't mean to do that, you mean for everyone to get equitable care, that you yourself might not be providing equitable care? As Dr. Morse alluded to, I've done several national studies looking at these exact questions, more towards the heart failure population. And I'll tell you, in these papers, people meant well. They meant, you know, they had this idea of trying to do the right thing, but still they were doing some of the wrong things. And so I think until we start to become more humble and understand that even just because we mean well doesn't mean that we do well, and we start to unravel and dismantle structural racism and really treat these social determinants of health, I fear we're going to be at the same place that we were 20 years ago, if not farther from that. And so I hope that during this time period with COVID-19, that people start to see that this exists, this is real, although it might not impact you at the time being, it may impact you in the future, and it does definitely impact your patients and different patients of color. So we have to use this as an opportunity to really educate the masses, educate ourselves, and look within to see how are we going to make the necessary structural changes needed to achieve equity in this country.
Thank you so much, Dr. Braden. I think we have a question from Stanley Buffon, and he's coming back a little bit in the conversation we had on flu and COVID. So I will read his question out loud, but as we want to have this as a conversation, we might also be able to give the opportunity to our attendees to ask their question by themselves. So I will read the question of Stanley Buffon, and then we can ask him later on if he got his reply. So his question: COVID-19 has highlighted many issues over here in the UK in terms of medical care for minorities, particularly Black people. How do we then develop trust in the community when it will seems as though it is safer to not trust the system?
Well, I don't know that I can speak for the UK in particular, because I don't practice in the UK, and there's clearly differences in the healthcare systems. But I would encourage patients, I mean, I even encourage my own patients to never be afraid to seek a second opinion. Doctors make mistakes, nurse practitioners, physician's assistants. We are not all knowing. And, you know, particularly in the US, there are providers who may not necessarily always have your best interest at heart. You know, for those people in this country who don't necessarily believe in a single payer system, one of the things that they sort of tout as the benefit of the system that we have is that there's a marketplace, and that there's an ability to shop around and seek other providers and get care at different places. Now, obviously, you know, that's sort of in some ways controlled by your insurance companies and other things. But I do say to patients, if you feel as though the provider that you are seeing is not listening to you, is not providing the care that you feel like is quality care, seek out a provider who you feel like is going to give you that. Now that can obviously be difficult, but maybe through word of mouth, maybe if you talk to friends and family and you have a friend who has a primary care physician or someone else who you know gives good quality of care. Again, I mean, this is worth your time. You know, I say to many of my friends, if you're willing to spend 5 or 6 hours waiting on your hairdresser, but not willing to spend an hour or two waiting to see a physician, that's a problem. You know, your health is worth it. It's not always convenient to go to the physician. However, we are willing to do other things in our lives that are inconvenience for vanity and other things. And there are providers out there. I mean, I hope that my patients would say that I run late sometimes, but that's often because I'm listening. And so sometimes that 15-minute interval that's there on the chart, I just can't adhere to that because I'm trying to listen to what my patients say. So my patients would probably say I run late when they're coming to see me, but that's because they know when they're seeing me, I'm going to give them time, and I'm going to give them hopefully quality of time. And there are providers out there who are like that. You just have to find us. And so again, there are, you can develop trust, but it may require you to drive a little farther, do a little bit more homework in terms of finding someone, talk to a few more people, get on the internet and do a little bit more homework. But there are definitely providers around who are just as interested in providing quality of care as they are in providing quantity of care.
I'm just going to chime in for a second and talk about just different levels of engagement too. So obviously, Dr. Morris has a lot of experience with the clinician patient interaction. I also think especially with COVID, a lot of this falls on, especially in the United States, just broader messaging around this condition. And it's been such a disappointing display of how to explain a serious global pandemic. And so there's so much disinformation and misinformation. So there's active disinformation of people peddling ideas that are not truthful, that are harmful in many ways because they have an agenda for whatever reason. Then you've got people who are spreading misinformation. You see this, and Dr. Thomas showed his smartphone. You can get information at the touch of a fingertip and really quickly right now. And a lot of that information, just because, as Dr. Morris said, just because you see a person in a white coat doesn't mean they don't make mistakes. Similarly, just because you see it on Twitter or Facebook doesn't mean is accurate either. So I think the way that we can do a better job of, at multiple levels, trying to tell people about how to develop trust. One is acknowledging there has been mistrust. There's reasons why there is mistrust. So understand, because we have this issue with voting in the United States. We're 12 days away from a really pivotal election. One of the key issues in the United States is how do we get people to vote? And a lot of people don't think their vote counts. And that's half the battle for a lot of people who are trying to suppress that vote. But part of the reason why people don't vote is because they believe that historically, and there's a lot of evidence to that yes, people have absolutely tried to undermine your power and undermine your ability to vote. Similarly, with health issues, you have to acknowledge that, yes, people have done historical harms. We have to acknowledge that. But now we've got to provide new, accurate information while simultaneously acknowledging the hurt and the harm that's been done in the past. So it's a balance and it's a dance. But I think that from a multi-level perspective, from a healthcare systems perspective to a public policy perspective, that's where we have to take the conversation.
I think we also have to be trustworthy. And that means that when we're out in the community and we're hearing things about our institution, we need to take that information back to our institution and let them know, hold up a mirror, because the people in the community are saying, I live in a 1 mile radius around your institution. You hang up all these billboards about how you're number one and this, that, and the other during the US World Report ratings. And our communities are dying from the very thing you have on the billboard. They see that. They see themselves as being used to advance the careers of others. Their suffering is used to advance careers. They say things like, you guys were here 2 years ago. You took blood. I did a survey. We have no results. So we come behind those of us. Look at us, all right? We come from the community, but we have to overcome all the people who came in before us and messed things up. So we have to be trustworthy. And we also have to recognize that there are people in the community that are very trusted, and they may not have any degrees behind their name, like the barbers. And I've heard a barber say something Somebody came in who had been in the hospital. People hadn't seen him for a while. We'll call him Joe. He said, I was in the hospital. They told me, they kept me for 3 days. They told me I had heart disease, and he pulled out a pill bottle. He said, they told me I'm gonna have to take these pills the rest of my life. Everybody in the barbershop is listening. TV's on, radio's on, but everybody's listening. And the barber says, Joe, if you take those pills, you won't be able to keep up your obligations. Dr. Hudson, do I need to explain that to you? So the docs know that some of the side effects of cardiovascular hypertension drugs might be erectile dysfunction. That's what the barber was picking up on. You won't be able to keep up your obligations. And I looked at Joe's face, Dr. Hudson, he's not taking those pills. And he's not going to tell Dr. Morris.
I would ask
him, avoid Dr. Morris.
I would tell him that hypertension causes more erectile dysfunction than those pills do, and so does diabetes. I worked at the VA for years. I have no problem having that conversation.
And so we need to have the barbers know that so that they're on our side, so that they can reinforce the message. So we bring the medical physicians and we bring them into the shop. They do their screenings in the barbershop. And again, the miniaturization means we don't have to be tethered to a hospital or a clinic. That's the strategy we're using. It's called HARE, Health Advocates in Reach and Research. And we'd love to have some shops in jolly old England. Come on, man, you got barbershops over there.
So that actually brings us to another point that we have, which is the narrative that researchers and professionals have around cardiovascular health and the delivering of the message to the community, and how our community would take that in the wrong way. Like, we have a lot of, like, history speaking, we have a lot of like discriminatory or racist narrative around cardiovascular health in the Black community. So this brings us to the question as, how is this narrative tied to what we have been describing so far for the community? And what are the type of narrative that you as a professional have been encountered? And because you know the community, you know how it felt. So maybe I will start with Dr. Morris, because I said she was ready to answer.
I mean, I think, again, our perspective is unique because we have lived in our own communities, as Dr. Hudson says. And so I think we have a perspective that is important. So, you know, when I was sort of coming up in this space and reading articles, sort of seeing that the non-adherence and the non-compliance and the low health literacy and all of these things, that, you know, my immediate reaction was, I reject that. It's not that those things aren't important, but it's more complex than that. I would not label an entire group of people non-compliant, non-adherent. And again, I think, you know, Dr. Breatha can speak to much of the work that's been done in the bias space with paid actors sort of delivering the same scripted lines about chest pain or other symptoms, showing that the perception of patients tends to show us as being non-adherent more so than other groups. So some of that is related to bias. Again, I think that sometimes patients have to feel trust, and I think they have to feel that in the clinical space, but they have to feel that in the research space as well. I think that diversity of providers, again, in the clinic space, but also in the research space. So for example, if you want to recruit a diverse cohort of subjects, you may want to think about having a diverse research staff to engender trust, to make sure that patients and research participants feel as though they're not being experimented on, and sort of, again, acknowledging that historical context. And then also sort of trying to make sure that you educate people about the hypertension, the diabetes, the obesity. If we're talking about physical inactivity or activity, acknowledging certain barriers that may be unique to our community and our spaces. You know, if you spent time in the hood, as Dr. Thomas says, or in our neighborhoods, you know that there aren't Whole Foods on every corner in our neighborhoods. There's not gyms and areas for physical activity or certain fitness spaces for physical activity in our neighborhoods. And that in many ways is by design. Again, acknowledging the historical context, acknowledging redlining, acknowledging the way that communities were built to uniquely disadvantage African Americans in this country. And so if we acknowledge those things, then the conversation with patients of African ancestry who live in those neighborhoods may be slightly different. And so then how we counsel those patients in terms of how to optimize their cardiovascular risk and how to maybe work around some of those unique barriers depending upon where they live or what their work-life balance is. Maybe they're working 2 jobs and they're a single mother and they don't have a nanny or whatever the particular situation may be. It is, I think, our responsibility as healthcare providers to ask those questions, to try to acknowledge how those barriers may be unique in certain communities, depending upon socioeconomic status, depending upon race, and then try to sort of change our recommendations or optimize our recommendations depending upon our patient's unique set of circumstances.
Thank you, Dr. Morris. Maybe other panelists want to tune in and give their opinion.
I would again like to echo what has been shared with the need for diversity. I'm not sure of how critical people recognize this issue is, but of all the diseases, we know that the leading cause of death is cardiovascular disease. The leading cause of deaths of African Americans, of Black people, our people, it's cardiovascular disease. But who's treating these people? When it comes to cardiologists, when we just look at just women and men, first off, 13% of cardiologists are women, period. Now, when we look at what percent is African American, it drops down to about 3%. That's a problem when we consider that there's been multiple studies that show that race concordant care leads to better quality of care. And even in, I think there's a study in a barbershop providing education about flu vaccine led to increased access to receiving flu vaccine, concordant care. So what are we going to do to diversify the field? We have to really start to manage the pipeline and start to think about how do we encourage people to say, like, you can be this, you can be a cardiologist, you can be a PhD, cardiovascular research scientist, you can do this. But this has to start really early in age. We have to start, and I think like a number of people have shared that at the K through 12, this starts much earlier, where we start to provide our people and people of color with the appropriate education, the tools and the motivation and the support to say, yes, you can do this, and to give them what they need to make it to that next level. Because if we're starting at an undergrad or even in grad school, med school, I mean, there's still a large drop off. We have to start much earlier because the talent is there. We just have to help it grow and help nurture it. The second point I'd say is that because we live in this society where there are so few of us, that it is important, like Dr. Morris shared, to identify a physician or a healthcare professional that you trust, to develop that relationship and to determine whether or not you want to continue receiving care with that person, because there may not be a person that looks like you that can provide your care. Unfortunately, we live in a society where there's social media and there's LinkedIn, there's Twitter. You can actually reach out to healthcare professionals to help identify a physician that might be able to provide that care for you. That happened just the past week, where I was not able to offer care for a person that's across the country, but I have a colleague. I belong to the Association of Black Cardiologists. I have colleagues throughout the country that we can easily help make referrals to help people get the care that they want and the care that they need. So I urge any patients that are listening out there to not lose hope, to not give up. We hear you, we're listening to you, we're trying to bring your voice lifted up and bring you to the table so that you can help with these research studies and help make sure that we're choosing the appropriate outcomes and objectives so that you're a part of the solution, because we know that what you think and what you say matters. And so I just encourage everyone to continue the fight, continue moving forward, because I think that there are allies that are growing amongst us and that we're getting to the point where we can truly achieve equity.
I really like, Blacks in cardio, because to me, COVID has said this: we're going to have to save ourselves. When I'm in the shop and they look and they see those numbers of disproportionate impact on Black people, and they see, unfortunately, the biggest microphone in the world, the White House, with experts saying, let's let it rip. Let's just let it go. Let's go herd immunity. Let's just let it go. In the Black community, that translates into they know who's dying. They know who's dying and they don't care. They're going to let it rip. What I've seen in response is, we got to save ourselves. I'm going to wear my mask. I'm going to lose some weight. I'm going to take care of myself. I think we need to build off of that sentiment, because it goes back to, let's get these underlying conditions under control. Let's start taking care of our communities. And I would submit that when we were doing this work in the barbershops, the physicians felt so excited. They'd never been in this space. They said, we like to adopt this shop. You know what the barber said? We will adopt the doc. So we want Dr. Morris and Jason, but Dr. Stanley can stay back in the lab because he got an attitude. You need to work on himself. That's what they'll tell you. And when we flip that and let them have control, they renovated space for privacy, for actual physical exams, Dr. Morris, in the barbershop. There is nothing that would prevent us from being off-site except for our own convenience. Now, in jolly old England, we think everybody's happy because you have a national health service and everybody gets care and nobody's turned away. So we think you have no health disparities in England. Am I right?
It's not true.
What? Not true. What? It's not true, given the austerity measures under this.
So access to medical care is not sufficient to eliminate these disparities. We have to have a different mindset to address, as Dr. Morris described, the social determinants of health. And this language we have, non-compliant, non-adherent, always puts the burden on the patient population. No, it's your system, it's your infrastructure that is a problem for us. We need to voice that. And to do that, we need Morris and all these folks here to be tenured. You know that word, right? And help you get through these systems. That's part of the work I do, to make sure when we get people in that pipeline, they stay in that pipeline and that they're successful.
I think you mentioned some good points there. I think especially scientists.
Sorry?
No, go on. You go on.
I like how you folks are so nice to one another.
You go on.
I was just going to touch. Oh, sorry. I was just going to touch on from what the other panelists have also mentioned. I think this is a similar theme seen across globally in terms of the social determinants of health and the barriers. They're not unique. This is all something that is a common theme that we see. And I agree with Professor Thomas, the importance of language and the tone of how we speak to our community. It's more of a telling off rather than it's okay, this is a safe space. Because when we don't have that for our own community, how can they trust us and we're in our own Black skin? It's nice to say, we need more Black faces. Also, redesigning the structure of the healthcare system. This goes from policies, this goes down to implementation. Effects of that, you would see changes in the uptake of flu vaccines. You see changes in help-seeking behavior, so you won't be reluctant to go. Uncle won't be saying, "Oh, I'll just drink this medicine that I'm used to back home, or this concoction that that my grandmother used to make. They would be willing to spot a sign and say, okay, this is a sign of, whether it's hypertension, medical help seeking behaviors applies not just to cancer, it could be anything. They spot a sign, the early warning signs, they go to their GP and seek help straight away. If not, they have 111 here in the NHS to call for further advice, and obviously they can walk into A&E for further support. But I think language, accountability, and acknowledgement, acknowledging that, yes, the system has failed us, but now it's not just complaining, it's what do we do about it? There are most of cardiovascular, yes, genetics play a part of it, but there's also, the social, economic factors that create the cardiovascular disparities. But there's also the positives, taking up more exercise. We're seeing more of our community, going to the gym. Granted that we're in lockdown, but more people are going out, enjoying fresh air. They'll say, I had a patient say that my bones don't ache since I've done 30 minutes of walk when they had leave. Their medication has been titrated a lot better, in fact, reduced because of their improved physical health. So I think with all these factors in place, it actually creates less hostility, and we break down the barriers one by one. And also translating some of these things into languages in our community that are spoken also helps reduce that barrier. They feel there's representation, and I think there's so much power in representation of seeing, oh, there's a Black clinician, there's a Black nurse, there's a Black receptionist, there's, Black researchers that are willing to listen to my voice. Again, it goes back to, I don't want to bring politics into this, but seeing that their voices are being heard and being represented, it makes them feel included. And I think that inclusiveness makes a difference to patients' lives.
So I was going to basically echo what was said and say that so your barbershop idea, I think is amazing, because what you find is that, especially with scientists, I mean, I'm not a doctor, so I don't know so much on the doctor side, but definitely I think as scientists, we fail to communicate our research to the community. We use language that the public can't access, and we put our journals behind paywalls and all sorts, and we're not disseminating that information to the rest of the public. So I think the idea that we can go into the communities and let them know what we're actually doing, and showing them that there's actually, like, there's a reason why we're doing what we're doing. We're not just doing it so we can get journals, or we're actually doing it that we can improve health and improve research so that lives can be saved. So I think that's it. I think that's amazing.
Jason, I think that that's such an important point. I have one of my best friends is actually writing a book. She's a horticulturalist by trade, or by training, and she's writing a book on the history of Black, I guess, sort of African-American horticulturalists, and how when African slaves came here, they were the ones who obviously sort of tilled the fields and contributed to the agricultural growth of many countries, including this country. And yet the stories behind that growth are often locked away in many of our institutions. And so for civilians, I guess, non-academics, to get access to those stories, including her, they can't. They can't access those stories because they don't have, logins to emory.edu or, University of Maryland.edu and other things, and they don't have access to our stories. And so I think that's a great point, is, even if we want to share our knowledge, sometimes our universities and or journals and other things don't allow the public to access that information.
Here's where Zoom can help as we do these kinds of sessions, and we're streaming live on Facebook and on YouTube. Maybe the next time we bring the barbers in, and now we're having a conversation with, the wisdom of the common man and woman. And many of the people in the barbershop made reference to, well, I take this, my grandmother talked to me about, they're hanging on to that African tradition. And I think that we need to embrace that again, not let that be marginalized. Just like Chinese traditional medicine, they're doing Western allopathic medicine in China. But guess what? They have a very robust Chinese traditional medicine. They have not let that go. I've been in Brazil in the Amazon. You cannot pick anything that's living because they've been exploited by pharmaceutical companies coming in looking for new products. So that remedy from Africa that somebody still remembers, you better write that recipe down. You better get a photo of that flower and that plant. It could save our lives. And Dr. Morris, you're absolutely right. There's a study looking at cardiometabolic disease and diet. Randomized study. US African Americans and Africans in Africa. They took the Africa in Africa diet and fed it to the African Americans. And they took the typical African American diet and fed it to the Africans. And guess what? The Africans started gaining weight and getting obese. And the African Americans on the African diet started losing weight and improving their cardiometabolic risk profile. That is buried in a journal that you can't get to. And if you got to it, it's so arcane you wouldn't understand it. We got to translate that. The African diet, traditional African diet, can save our community. Don't let them denigrate it. I want some African recipes. Where's that African cookbook to save my life? Come on now. You get the docs here to all sign off on it. That's what it means to take charge of our own health in our own communities, in our own way. And if that means we reach into our own little pockets and fund it ourselves, that's what we do. That's what COVID's teaching us. They are not going to save us. We got to save ourselves.
I want to put a plug in. Association of Black Cardiologists has a cookbook, kind of like that, but you can find on the website to help with your cardiovascular health. But I also wanted to state that in terms of interacting with the community, and this is something that's near and dear to my heart that was taught to me by my mentors when I was a cardiovascular fellow, is to speak to the community on a regular basis. And especially during February, Black History Month and Heart Health Month, to take the time to meet with different community members, meet with the different sororities, fraternities, with the other local communities, with the churches. That's something that I prioritize wherever I live, to meet with people and to speak with them. And the amount of joy that you get just from that, from experiencing talking to people and seeing that people say, you know what, I'm actually going to change the way I'm eating or change the way I'm exercising. This reinforced, and this is encouraging me to change what I'm doing today, and to do better, and to live better, to live stronger. And so there are, wherever you live, there are different pockets, even if there's a small proportion of people groups of color where you live, they exist, and reach out to them. It brings them pride to see you where you are as a physician, or as physician scientist, or as a scientist, trying to do things that achieve equity. And so I just encourage each of us to not stop doing these things that oftentimes don't receive academic credit, but they are important for the growth of our communities. And this common mindset that you're going to care about your community that fuels the community to lead and do better. There's, at my center, it's Sarver Heart Center, we actually have a minority health committee who embraced me when I came to this university, even before I came, and made sure that I felt welcome, and that have supported me day after day. And they've actually have developed a national platform to be able to share what it takes to improve cardiovascular health for the community, to get people of color involved in clinical trials and studies. And so there's a lot of opportunity to share what we can do for our different people groups by just being willing to go out and chat with them, talk with them, and let them know you care.
February. So imagine this, Association of Black Cardiologists and Blacks in Cardio have a February series, town halls, We're going to translate the science and do, hey, we're going to come into your kitchen, Khadija, and you're going to cook up a nice healthy meal. There's no reason we can't use this to bring them into our homes, to demystify. We all have these degrees now. Sometimes the young people look at me and think I've always had this degree. I didn't always have this degree. I was a confused young person at one point. People came into my life, mentors. Sometimes I had tour mentors, but I made it, and we can help others make it. But we need to take advantage of February. Don't let this be one and done, Black and Cardio. Keep us together. We can start planning right now for February 2021 for a whole month on health. The healthy Black family. Imagine that. Come on, Dr. Morris. You know we can do it.
Definitely. I think this is a great idea. I will definitely keep up. And we actually have been very much supported by the Association of Black Cardiologists that has been like supporting us, treating us, and be like, let's go, let's do this together. So it's amazing. And thank you all again. I will let Dr. Morris say, because I feel like she was about to say something. Sorry.
I just said I'm in. Count me in.
They're gonna come to your kitchen too. And I want that cookbook in every Black barbershop. Send me a box. What I got to do to get that Black cardiologist cookbook?
Thank you so much, everyone. I will just go. I'll give back to Jason if he has any question. But we are a little bit over our time.
Really?
But,
it's over already?
Oh, wow. That went by really quick.
It's been yes,
quick.
Yes, we've gone over our time, but honestly, I'm gonna go back and watch this again because I feel like so much information was dropped in this chat, and I'm excited actually about what can be done in the future, and to see it's been a very refreshing conversation. Just hearing what you guys are doing over there in the States, and seeing like-minded people who have the same mindset on working in the communities, and seeing the ideas that like the barbershop ideas. These are things that we could mimic in our communities over here, maybe in other environments, not just barbershops, maybe youth clubs and all sorts. So this has been a conversation where it stemmed a lot of ideas. And I know I speak for myself, but I'm sure the other organizers of Black in Cardio will agree that this is definitely not the one and only. This is just the beginning, and we're gonna get a lot of things done in the future. So yeah, I'm very excited, and I just want to say thank you to every single one of you for joining us. It's been amazing. It's been amazing having you. Thank you for your time, and I hope this is going to be even like there's going to be further conversations in the future. So thank you so much.
Thank you, everyone. Before we go, I really want to stress out the fact that today we wanted to talk about how to talk about changing the narrative around cardiovascular health in the Black community, and how we can destigmatize how the cardiovascular health is done in research and therefore perceived in our Black community. So before we go, I really want to ask each of you to say one thing very quick on how we as a researcher, because we are mainly researcher here, we can switch this way of researcher presenting your result to our community. If you have one advice to say, one thing that you want all your fellow researcher to know about how to communicate their science in a much less harmful way to the community, what would you say? So I will start with Dr. Hudson.
Yeah, sure. I would just say thanks for inviting me, and really good to see you all and share these ideas. It's really fun to be here. In terms of what to say, I would say just know your audience. The more you know about your audience, and we're not a monolith. I can't remember who said that earlier, but there's going to be different age and developmental considerations. There's going to be differences across gender and social class and all that. So the more you know about your audience, the better. And the more you know where people get their information, the better. So that's what I would say.
Thank you so much.
They're waiting for, we're being kind. We're waiting for you to call on us.
I would second Dr. Hudson's comments. And I would also say, I've had many, again, my research cohorts are primarily composed of Blacks and whites because of the demographic of our population here in Atlanta. But I've had so many Black patients say, you know, I'm only doing this because I want to contribute to science. So I don't think that we can assume that Blacks are not interested in, that their mistrust is so great that they don't want to participate in studies, they don't want to enroll in clinical trials, that they don't want to be part of research studies. Again, I think they just want to feel as though they are in a trustworthy environment and they're with a research team that is not taking advantage of them. But I've had so many Black participants tell me, you know, literally that they just want to be here so that they can contribute something in the scientific space so that they can make the world better for other participants. And that really always sits so strongly with me. And so I think we're not a monolith. We can't make assumptions about patients based on any race, ethnicity, and we should just give everyone a shot, period.
And I've got a very short poem. It's a piece of wisdom, Chinese saying about leadership. Go to the people, live with them, learn from them, love them. Start with what they know. Start with what they know. Build with what they have. But the best leaders, when the work is done, the task accomplished, the people will say, we have done it ourselves. That's what we need to do.
Great, great. Thank you so much. So I'd like Dr. Brett to say one very short and Ogechi, and then we'll resume this session.
Thanks again for having me as well. I'd say the most important thing is to listen, because our people are speaking, they have a voice. We have to be willing to listen and to uplift their voice. Also, as an implementation scientist, it's important that we figure out how to, any change or thing that we're going to do to achieve equity, we have to figure out how it's going to last. How can we use our community? How can we change our policy so that what needs to change changes and it continues and it doesn't just end because the grant's over? Our community has a clear reason for mistrust that is persistent and pervasive, and we need to unravel the system that's causing the mistrust by listening and figuring out how to achieve equity that lasts.
Thank you so much. Gechi?
It's similar to what everyone else has said. It's creating a safe environment, a trustworthy environment, ensuring that they are being listened to and included. I think inclusiveness, whether it's in a study or as a patient, is paramount to progressing ultimately in healthcare for the Black community. I did love Professor Thomas's idea of the barbershop idea. I think that is also one of the best ways to include the community, and they feel that they're part of that change. I think with politics as well, it doesn't help that, you know, you're not being represented in these spaces, but if you can do it on a local level, that can be transmitted to a moderate level to a higher level of government. And at the end of the day, it's something they can feel proud of, that even though they're not an academic or clinician, they feel that they've contributed to their community, our community.
Thank you so much. Thank you so much for your time. Thank you so much for this panel. I think we all really, really enjoyed it. And
for sure,
we touched on a lot of things. I think Jess, you want to say something? I'll let you say.
No. I was basically supporting you. That's all.
He's your amen corner. He's your amen.
Tomorrow, we're actually going to talk about the second part of this specific panel on changing the narrative about around cardiovascular health in our community. We are bringing together a lot of professional, but also community advocate and wellness coach tomorrow at I'm very bad at timing, 9 a.m. Pacific time. I know my time better, so please. So 9 a.m. Time here, which is probably 12 p.m. on the East Coast. The idea is to, again, bring back this conversation, talk about how we can really shape the narrative around this, how we can talk to our people, and like Dr. Thomas bring it, how we can talk to our people in a barber shop about cardiovascular health in the way they will understand, they will relate. So we invite everyone to come join us tomorrow. And please, Dr. Thomas, let the barbershop and all the community to know about this event tomorrow. They can watch it on social media, and please ask questions. What we want is to let their voice heard. That's the most important thing for us. And thank you everyone again. And hope you keep on following us, and see you tomorrow for the next panel.
Bye-bye.
Bye.
Thank you very much.